Catherine comes to see you because she says she has been having problems sleeping at night. She has many bad dreams, and most of these have to do with her parents. Catherine's aged parents were both living with her until about 2 years ago, when her mother died of diabetic complications. Catherine had been extremely involved in her care until she died. Catherine's father lived on, but gradually became demented to the point that he was unable to feed himself or handle his toilet needs. He did not recognize members of the family, and on 2 occasions he was found wandering around naked in the neighborhood. Catherine endured all of these difficulties for 2 years and only recently forced herself to place her father in a nursing home. His emotional reaction to this experience was very negative, and in an agitated state he fell down the stairs of the nursing home and broke his hip. An infection set in, and he died a few days later. Catherine relates that she has frequent crying spells and is constantly preoccupied with thoughts of her parents. She feels that she has let them down and was directly responsible for their deaths. She now finds that her obsessions about this are so unrelenting that she is unable to keep up with her normal activities, and her family is becoming very concerned about her. She has no appetite and has lost 20 pounds in the past few months.
Stories like Catherine's are all too common in the work of the minister, and I submit candidly that pastoral care for people like her is a reason why many people go into ministry. Connecting with fellow members of the body of Christ and helping each other in a time of need is what church is all about. Hello, this is Jonathan Adkins. I will be leading this short presentation on depression as part of our seminary course on diagnosis and referral of mental health conditions. The Webster's Dictionary description of depression is either a general state of feeling low and sad, or at its extreme, a mood disorder marked by excessive lethargy, withdrawal from relationships, and maybe leaning toward suicide. It is important to note at the top of this discussion that this definition covers a spectrum of possibilities, because depression itself exists on a spectrum. No 2 cases of depression will ever look quite the same, nor will any 2 forms of treatment ever suffice in covering all the needs of a person in depression. Indeed, there was a great interest among our classmates in this course to give this presentation, and I think that is due to the fact that depression touches many, many lives. Like you, I have seen it, felt it, and feel compelled to help with it wherever I can. The scope of this course is to help me as a pastor or chaplain to see these conditions in the people I serve, so that I provide the most loving Christ-like support that I can. Therefore, my responsibility as a pastoral caregiver is to explore what depression looks like, and to know my responsibilities once a person in depression seeks my help. Within the texts for this course, there are some differing descriptions of what depression is, some looking to it simply as a natural emotional state, while others mark it as a clinical mental disorder within the scope of psychiatry. Collins and Culbertson mostly view depression as a medical disorder and the diagnosis of the condition in those terms. They explain that assessing the severity of depression is a complex process, which requires answering questions such as whether the individual has full contact with reality, the presence of suicidal thinking or a vegetative state, and the degree of subjective distress. These signs indicate the presence of a serious depressive episode that may require psychiatric intervention, such as medication or hospitalization. The minister must have a reasonable idea of the individual's level of functioning before the depressive attack, and significant changes are usually taken more seriously. In contrast, Brown teaches from a feminist therapy perspective that depression can be seen as a resistance to the loss of oneself and voice. She says it is not diagnostically and conceptually useful simply to label it as a disorder. The author explains how she worked with a client named Paula, who was diagnosed with major depression but had ignored it while pursuing life goals of education and career. Paula had become numb, less attuned to herself, and less in relationship with her inner voice. Her depression was a manifestation of her health and strength speaking to her, a strenuous last-ditch attempt to get herself to slow down and listen. The author argues that feminist diagnostic questions are essential in understanding what depression tells about a person's disconnections and internal silences. Looking at this story in tandem with Colin and Culbertson's perspective demonstrates that there is no one-size-fits-all approach to identifying or treating depression. Therefore, depression requires different treatment plans for each patient based on individual need. Again, referring to Collins and Culbertson, they explain that crisis intervention for depression may take many forms, depending on the severity of the disorder. Individuals with extreme depression may require psychiatric hospitalization for the initial phases of treatment, where they would undergo antidepressant medication, psychotherapy, and various activity therapies. Pastors and chaplains can assist individuals in making contact with psychiatrists or hospitals and help them avoid situations where they would face such scary psychiatric evaluations alone. Ministers also can offer continued assistance, support, encouragement, and spiritual guidance to the patient during hospitalization. Pastoral support in a hospital setting should be positive, supportive, and reality-oriented. If suicidal ideation is present, spiritual support emphasizing God's love, forgiveness, and concern for the suffering patient can be extremely valuable. Now, we as ministers in the church will often find ourselves to be at the front lines of helping with this condition. The pastor of a church meeting for a personal conference, or the chaplain in the hospital could be the very first person to whom a parishioner or patient admits that he is facing a depressive episode. It is important for ministers to be ready for this moment with a proper understanding of their role in this critical diagnostic step. Some pastors and chaplains come to this work with a counseling background and are qualified to intervene in these situations. However, most ministers traditionally are not mental health professionals, not even hospital chaplains as I aspire to become soon. Therefore, I should never put pressure on myself to treat or fix such a disorder that is not within my purview. What I need to do is to stay alert, to see depression in the person I help, and call for the right assistance at the right time. First, I ask, is this an emergency? Is the person in the middle of a depressive episode that could lead to some kind of harm? I would look for some of the following qualities in the person: a history of depression before today, threats of suicide or harm to self, threats of homicide or harm to others, not in touch with reality, catatonic or non-responsive states, manifestations of physical or emotional pain. If the answer to any of these items is, yes, I see that, it is important that I stay with the person and gently call 911 for help. After the emergency is concluded with some kind of medical treatment, maybe a visit with a psychiatrist or a stay at the hospital if acute, I, the chaplain, can help the person explore what brought her to that place. Some of the common reasons for depression include guilt about a past choice and the consequences that followed, poor self-esteem brought on by childhood or current events, directing anger at self instead of the proper source, grief over a recent loss, such as death, divorce, career, or something similar, grief over a loss in early life that creates a mistrust of the future, saying things like, I'll never be allowed to be happy. Or if the person is out of touch with reality due to dementia, excessive stress, and other sources. While talking to the person, I remember and practice some of the important skills necessary for a quality chaplain visit. During, among others in the field of chaplaincy, teaches me to steer away from asking lots of questions. Questions seize too much control of the conversation and take away the person's right to his own self-discovery. Have you ever been in a conversation where you felt frustrated by the other's questions because he clearly was not on the same page as you? Instead, focus on direct statements from observations. I see your tears. That is very painful. You miss your mother and father today. I hand these direct statements to the person and let him construct the rest of the story while I listen. And most basic of all, I practice ministry of presence. A past teacher of mine described chaplaincy as the art of being God's representative during a crisis. When a person is looking for God in that crisis, she sees me. Many people naturally move away from a person in pain because empathy with her pain hurts. It falls on the minister to walk heroically toward that pain and be there for her crisis. Of course, I do this within some boundaries to protect myself along the way. I show up for the emergency call at the hospital or elsewhere, and I stay until the situation calms down. Afterward, I schedule a recurring time with the person, maybe once or twice weekly at first for an hour, to give her time to talk, think through her pain, and share FaceTime with me that says, I care about you. I encourage other people within our faith community to do the same so that the person in pain sees that she has a community of caring individuals. The church thrives on people being in communion and community with each other. So I circle back to the opening case study of Catherine and ask, is Catherine's situation an emergency? She is withdrawing from her family, chronically sad, and barely eating to the point of losing weight. So yes, this is an emergency that calls for medical help. She is in a reasonable state of mind as I speak to her, so I ask her to drive herself to a physician's office that she trusts, and I follow her in my own car to be there while she seeks treatment. Once Catherine is properly under a doctor's care, I schedule weekly meetings to talk about her situation, such as the next 4 Thursdays at 11 a.m. I help her identify some of the reasons for her depression, including guilt over past choices she made about her parents' medical care, plus the natural grief that has followed their passing. I hand her obvious statements like, you feel guilty about what happened to your father, and his negativity about nursing care was not your fault. Catherine can take these statements and begin to construct meaning that strengthens her to function in a healthier way. If she finds it helpful, I schedule a time to visit her parents' gravesites with her and be present with her in her grief. Lastly, I encourage Catherine to join the caregiver support group in our church, where she can talk to others who have spent a long period of time helping a sick family member. Catherine can connect with others who can relate to her pain. My prayer for all of us in ministry is that we have a deep sense of compassion and empathy for those in our care who deal with depression, and that we carry the light of Christ into this dark place to build communion with our fellow humans.